Today we're going to play a little game. Here I have this diagnostic deck of cards, and in it I have a list of potential diagnoses that could be causing your lower back pain. And we're going to work through these one by one to help you figure out the most likely source of your back issue. Off the screen I have my beautiful wife who is going to role play someone suffering from lower back pain, and you can see here she's going to give me some basic information. Now here's kind of the interesting thing. She doesn't really know much about back pain. She hears me talk about it all the time, but because she doesn't know about it, she's just going to share kind of randomly, here's the rule, pain somewhere in the lower back. She's going to draw it up here in a moment, and we're going to cycle through figuring out the most likely source of her pain, and the game ends when we get to the final card standing. So stick around for this entire video. If you're suffering with some type of back pain, you want to figure out what's causing it. By the way, my name is Dr. Charlie Johnson. I'm a physical therapist. I have a board specialty in orthopedics, and I help people all around the world dealing with back, butt, and sciatic problems figure out what's going on so that they can fix it. All right, so the first thing she's going to do is fill this out. So I want to know where she hurts, what makes it feel better or worse, when did it start, and how did it start? So go ahead. Where does it hurt? Let's start with that.
Okay. Right in the center of my lower back, right here.
Okay, my wheels are turning.
Okay.
Go ahead. So we know where it hurts, the center of her lower back.
Yep.
What makes it feel better and what makes it feel worse?
Better, I would say walking or standing.
Okay, just do a frown face for the worst.
Okay.
It's too slow.
Okay, sorry. Worse is sitting and lifting stuff.
Okay.
Handwriting on point.
When
Yeah.
did it begin?
It was about 2 weeks ago.
Okay,
This red is not very good.
that's okay. And how did it begin?
Well, we were moving, and so I was moving a lot of boxes.
Okay.
So
All right, so now given this information, the first thing we want to do is we want to rule out big, ugly, scary things like cancers, fractures, and infections. And so I'm going to ask her some more questions. Right off the bat, just know there's about a 0.6% chance that somebody presenting with back pain would have cancer as the cause of their back pain. So we're talking 6 out of 1,000 people. It's not very common, but it could happen, and ideally we don't want to miss it.
Yeah.
All right, now there's a cluster of findings that came from an article in like 2005, not that you care, but this is like what's going on in my brain, and I'm just sharing it for you. Okay? That basically looked at a cluster of 4 different findings, and it found that if you had none of these findings, you could rule out cancer with 100% certainty, basically throw this thing down and say you don't have it. But if you have other findings, then we need to maybe be a little bit more suspicious. So first things first, are you older than 50?
no.
Okay, so she's younger than 50 years old. We don't take any one thing in isolation. Just, are you greater than 50? The answer is no, she's not. Do you have a previous history of cancer?
Yes.
Ah, she does. Ooh. Okay, that is actually the biggest predictor that cancer could be the cause of your lower back. Now, there are some higher risk cancers like colon cancer, prostate cancer, things like that are more likely to metastasize to the spine. What kind of cancer do you have?
It was skin cancer.
Skin cancer. Okay. Now, luckily, it still is a cancer, but there's lower likelihood that that would metastasize or travel to the spine. So I'm going to say, yeah, maybe we can't throw it down yet, but let's keep asking questions. So do you have any unexplained weight loss, meaning you're losing weight, but you're not sure why you're losing weight?
No.
Wouldn't that be nice?
That would, yeah, I was actually kind of thinking that.
All right, so no unexplained weight loss. Awesome, that is a red flag. And then the last thing would be, have you tried natural treatment and then failed to get better?
A little bit, I have.
Okay, now my question is, was it good or was it not good?
Well, it wasn't very good.
Okay, what do you mean it wasn't very good?
Well, like, I went for like 2 weeks, but they were giving me like a bajillion things to do.
Okay.
And like, I didn't follow it very well because it was like too much stuff to do and I was too busy. So
Got it.
I would say I kind of tried PT before, but like it wasn't very thorough.
Got it. Okay. So it was almost too thorough because they were doing a bajillion different things.
Yeah,
and if you're
that's
doing everything, then you're not doing any one thing, which means you're lost and confused. And that's because they're lost and confused. All right. So to be clear, you're not greater than 50. You do have a previous history of cancer, but it's low risk as far as traveling to the spine.
Mm-hmm.
You have tried PT, sort of, but I'm going to say not really because you were doing a bajillion? A billion? Did I say?
No, I said bajillion.
Okay. And you don't have any unexplained weight loss. So I'm going to say pretty much right now, I'm going to keep you. I'm going to treat you. And then if we don't see progress, maybe we need to revisit this card, but cancer would be gone.
Low.
Pretty low. Pretty darn low, okay? Now, if you do have a previous history of cancer, colon cancer, breast cancer, prostate cancer, something like that, if you haven't already, an x-ray or blood work to look for markers of inflammation in the blood, something called an ESR, erythrocyte sedimentation rate, is where we might send you first before engaging or starting PT, all right? But you don't have those things. So now, fracture. So Cluster of findings. Again, another article in 2007 where we take a cluster of findings and we say, hey, if you have these findings, these 4 things, or at least 3 out of 4, you have a bug on your head, then the likelihood that you have fracture as the cause of your back problem goes up.
Okay.
So fractures, as far as spinal pain, are more common in people who have who are much older and or wiser. So folks who have, say, more than 65 to 70 candles in their next birthday cake. Okay. You weren't 50, so you're not 65 to 70, right? No. Okay, great. You are a female, though.
I am.
So for whatever reason, females tend to have more vertebral fractures, bony fractures in the spine than males in many cases. Did your back pain start with any type of trauma?
No, it wasn't a fall.
It wasn't a fall. It wasn't an accident. So I'm going to say there was a moment in time, and it is possible, by the way. Like if I see an older female, like I mentioned, who was bending over and picking something up, and they say, ow, I hurt my back in that moment, and they have this next thing, a history of corticosteroid use. So do you have any other health conditions which require you to take steroids?
No.
Okay, got it. You probably have good bone density. This is the concern. You will sometimes see what we call like wedge fractures, whereby you're picking up a box or something heavy. The classic example is an older woman with lower bone density, maybe a history of smoking, steroid use, bones aren't that healthy, and they pick up like a laundry basket. And then they have a fracture. Bug really likes you. They have a fracture in their vertebrae, whereby if this is a regular bone, it does kind of this. It gets a wedge fracture. It kind of gets crushed on the front side as you bend forward. All right, but again, because you're relatively healthy, you don't seem to have any bone density problems, we're gonna probably put that in the back of the card deck.
Do we take it out of the deck?
Good point. Let's just get rid of it.
I think we take it out of the deck.
Now, one thing though, just to expand upon this, that you will often see, let's just say you have 3 out of 4 of those findings. You're greater than 70, you're a female, you have some type of trauma, a fall, an accident, you bump into something pretty hard, you have a history of steroid use or reduced bone density. One thing you'll often see with fractures that I'll be telling is, stand on up for a second, and face that way.
Which way?
That way.
This way?
Nope, this way.
Okay.
Great. Is you will see point tenderness right over top of the spine. So you'll see these, you'll have these little bony bumps. Everybody has seen these, like little stegosaurus. You have those bumps, we call them spinous processes, and you will almost always have just tenderness. It'll be like what we say exquisite tenderness, really tender, just to touching the bone itself if there is some type of spinal fracture. All right, so put those things all together. She doesn't really have enough for me to be concerned, so I'm gonna throw it on the table, not a fracture. Infection. We'll see this often whereby somebody has the onset or the relative onset of back problems, pain somewhere in the lower back, with just not feeling well. So maybe there's a fever. We define fever as greater than 100.4 degrees Fahrenheit. Nausea, vomiting, chills, sweats. You haven't anything funky like that?
I haven't had any of that.
Good, okay. So we're gonna say not infection. By the way, again, these things are rare. Fracture is like less than 1%. Infection pretty darn low as well. All right, now sciatica. Dun, 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 right? Sciatica, pain, numbness, tingling, basically going down the leg. You don't have any pain, numbness, tingling going down the leg?
No, it just stays right in my lower back.
Got it. So sciatica is off the table. Now, if you weren't sure, what we could do, if you're like, Charlie, I don't believe you, I think I have sciatica because I was told it could just cause a back problem, that's fine, don't believe me. But what you could do is you could take her legs and you could just straighten them up. So go ahead and kick this leg straight. Pull your toes up first.
Okay.
Yep, now straight up one leg. Cool, you okay with it?
I'm okay. Yeah.
Pull the other toe up, straighten up the other leg.
So this is nerve pain, right?
Yep, if you do this test and you get zapping down the leg, then this would indicate nerve pain. Okay. And that test is a really good screening test. So basically, if you do that test and it is not painful, you can be 95% or more sure that you do not have sciatica as the cause of your pain. Here's the deal. Clinically, it wouldn't make sense for me to do that test because you don't have symptoms down the leg. All right, so I'm just showing and talking through it for anybody watching. Not sciatica. Piriformis Syndrome. The piriformis is a muscle deep in the glute. It's down here. What we know about referred pain patterns, when I say referred pain, I mean pain that is felt in one area of the body but is caused by another area somewhere else, another problem somewhere else. So what we know about referred pain patterns is that upstream problems in the back can cause you to feel pain, say in your butt, in your SI joint, in your thigh, in your knee, in your leg, in your plantar fascia, anywhere below. But a problem in your butt is not going to refer upstream, go against the flow, if you will. All right, so she doesn't have pain in her butt. She only has pain in her back, in the center of her lower back. So we're going to say piriformis syndrome. That's not it. We don't even need to test for it. Cool. Disc. Should I just jump right to it?
Let's jump
All
there.
right,
Yeah.
so disc is the most likely source of her symptoms, probably. Let's start one by one and see if I go back on myself at all. All right, so first things first, probability-wise, when somebody presents to me and they say, I have lower back pain and it's here somewhere, above the level of the belt line, we'll say this is the level of the belt line, we'll call that the lower back. There's roughly, based off the evidence, a 41% chance that the cause of pain is due to a disc problem. There is roughly a 31% chance that it's caused by a facet joint or a joint problem in your lower back. They're between the bones in the spine. There's about an 18% chance that it's due to an SI joint problem, and about a 10-ish% chance that it's due to a nerve problem. Don't even ask me how that made it in there, because you ain't got no leg pain. I don't get it. Okay, but that's what some of the research suggests. So the most likely source of her symptoms, as soon as somebody says, I have pain right here, is between disc and joint, all right? But joint pretty much drops out right away, because what we know is that if you have joint problem, a facet joint problem in the spine, you will have one-sided pain pretty much at the level of the joint problem. It does not cause central lower back pain. So if you have central lower back pain, disc goes way up in the probability and joint goes way down in the probability. So let me keep the card and keep talking through it. What makes it better? What makes it better is walking. This doesn't give me a whole lot in and of itself, so let's keep going. Sitting and lifting makes her feel worse. Facet joint problems may make somebody better while walking or while sitting, so it's kind of a wash. But then we put this all together. 2 weeks, seems like there was a very clear injury. It's acute pain, it's not chronic pain. And she did it moving boxes. So when I see somebody who, how old are you?
35.
Is younger, otherwise healthy, and injures himself while lifting loads repetitively in this forward bent position, and things like sitting and lifting make her feel worse, then you automatically start to jump to disc problems. The disc is generally more sensitive to bending, lifting, things like that, and is often more injured than, say, a joint problem. Now, to go a little bit further, coughing, sneezing, is that a problem? Coughing, sneezing, straining?
No, I don't think so. Not too
Okay.
bad.
That would be against a disc problem, by the way, all right? So there'll be one thing where it'd be like, oh, I was thinking it was disc, and then she said coughing, sneezing doesn't make it worse. I'm like, what's that? Come on, you're supposed to say. It is, all right? So oftentimes coughing, sneezing, straining will make disc problems worse, because we know that, we call that a Valsalva maneuver. If you exert any type of force, it increases pressure within the spine.
Mm-hmm.
Our symptoms, when are symptoms at their worst? In the morning, in the afternoon, or at night?
Usually in the morning.
Okay, so that puts disc higher up on the probability list as far as the most likely cause of her symptoms. So disc pressure is highest in the morning, and so you'll often see disc pain is worse in the morning. So far, given her age, by the way, joint problems are generally more common in people who are older than 50. Nothing against people who are older, but this is where you start to see like degenerative joint disease, facet joint hypertrophy, so you're getting some bony kind of growth. Did I spit on you?
No, it was a bug. It's okay.
Some bony growth and or enlargement of the joints in the spine. Picture somebody in your family or somebody you might know, they have like their knuckles are all gnarly looking. They've got those knobs on their hand. That's osteoarthritis. So you'll see like the arthritic stuff affect these joints and cause pain in these areas. But she's younger, so it drops it down. Morning is the worst. And based off the way that she injured herself, she's got some type of mild disc protrusion, most likely.
You know, fairness, I haven't really coughed much or been like sneezing a lot lately.
You want to cough right now?
No, I'm just saying.
Right.
I'm just saying.
This is the most likely cause to start. All right, let's just walk through these. We kind of talked about joint. She's less than 50 years old. Oftentimes, walking will make some of the joint problem somewhat worse, walking or standing. And if you think about it, joints, when you bend forward, you're actually creating more space for the joints. You're gapping them. So if these were the bones in the spine, as you bend forward, picture me doing this, you actually create space in the back here.
Over here.
Yeah, but what you also do is you stress out the disc. You put more pressure on the front of the disc, which increases the pressure on the back side of the disc. So the fact that you tell me, hey, walking is better, well, what happens when I bend backwards? I close the joints in the back of the spine. And what is walking? Well, if I take a stride, I'm almost doing a mini back bend. And so you will see, and we could go through an exam here, you would see that if I were to, I'm kind of telling you now what you should and shouldn't do, but if I were to take her through an exam, I would see that if she rotated and extended to one or the other side and or went straight back, she most definitely would get some type of pinch if she had a joint problem. You might also get it with a disc problem. But the fact that when you're sitting and you're taking the stress off the joints, you're actually getting more pain, that tells me it's probably not a joint problem. Probably more disc. Disc is still up there. Joint, I think we're going to throw off the table pretty much. All right. Brain. Charlie, are you telling me I'm making this up?
Is this all in my head?
Is this all in my head? Don't get me started, folks. I get this stuff all the day. It's not all in your head. It's very real, the pain that you're experiencing. But we do know, and there's plenty of neuroscience to support this, that the nervous system can become sensitized. We call this central sensitization, whereby the brain makes a bit of a mistake. The pain that you feel is very real here, but it's not driven and or caused by, if it is due to the brain, I think it's the disc, okay? If it is caused by the brain, it's not due to damage of the joint and or of the disc in this case. It's instead due to like a perceived danger. So you get sensitivity. Maybe it starts as a disc problem, but then over time you actually learn to experience the pain. You get used to it. And so the reason this is not brain and or unlikely to be brain, number one, it just started 2 weeks ago. So it's very recent. It's not chronic. You're still in that kind of acute injured stage.
What would be chronic? What would be considered chronic?
Greater than generally 3 to 6 months.
Okay.
And why do we say that? Because most things will heal within a 6-month time frame. So if you break a bone, guess how long it takes to heal a broken bone? In most cases.
6 weeks?
Close, yeah. So basically 6 to 8 and or let's just say you don't have the best bone quality. 12 weeks.
Okay.
Right, so we're talking maybe 2 to 3 months, something like that, to heal a bone that's broken. And so if a bone can heal in 2 to 3 months, you'd probably get that most other things. Disc, for example, can heal in like a 6-week time frame. I lied. You were blowing out the side of your mouth.
Sorry.
Sort of distracted me.
Sorry.
Discs heal, most of them, in like a 6-month time frame.
Oh,
There's a difference there.
Oh,
all right.
There's a big difference.
I got confused when you started blowing stuff at me. All right. So a 6-month time frame, most people, like 75% of people with disc herniations will be better. All right. So we'll say 6 months and beyond is considered chronic. And so if your body is meant to heal almost everything within a 6-month time frame, why do people have pain for a year, 2 years, 3 years, 4 years? It's either because they're picking the scab because someone hasn't taught them what they need to do to stop making the problem worse, and or they've learned it.
Got it.
All right, so you've got acute symptoms, not chronic. There is a mechanism as to why it started. Lots of people with symptoms that are driven centrally by the brain or the mind, they're like, well, it just started and I don't know why. I think it was when I was moving boxes. I don't know about you, when I hurt myself, I know when I hurt myself. I don't hit my finger with a hammer and say, I didn't feel anything, and oh, I hurt the next day, and oh, I think it was the hammer that hit me the other day, but I didn't notice it. It just gets weird. It doesn't make sense. All right, you have very clear things that make you better and worse. For the case that we're talking about now, brain is off. Myofascial. Myo, muscle, fascial, fascia. That like white tendony stuff.
Tissue?
Tendony stuff, yeah. Like the tendony stuff in the steak when you're cutting through it. All right, that shimmery stuff. So
I cut that out.
Yes, you do. All right. There's very little evidence actually suggests that muscles are a significant contributor to lower back pain.
Okay.
Now, you can push on back muscles, and it might hurt. But that does not mean that the muscles are the cause of your pain. What allows your muscles to hurt? Your nervous system. Your muscles are just a piece of steak. All right? And in and of themselves, they don't feel anything. And so that which plugs into it, the nervous system, is what allows it to feel or experience whatever sensations you experience when you push on it. So you say, my muscle is tender. No, your nervous system, which plugs into that thing, is allowing you to feel that tenderness. And so now what we believe to be true is that, let's just say you have tenderness in your butt cheek or something like that, or in one side of your lower back, your quadratus lumborum muscle. You'll see this all over the internet. I have trigger points, tender points. Well, if you have an L5 problem, then whatever muscles are supplied by that L5 nerve are going to be sensitive or tender to touch. So you'll say, oh, my calf is really sore. Can you work that out? Well, your calf is sore because the L5 nerve is irritated and it's making your calf sore. It's not your calf muscle itself.
I see that.
So we're going to get rid of that until like evidence proves otherwise. SI joint problems are almost always below the level of the belt line and in the buttock. You don't have symptoms below the level of the belt line. It does not cause central buttock pain. Therefore, we're going to say not likely. We're back at cancer. We still have that in deck of cards. We're going to treat you. You're going to get better. And so it's a disc problem. We didn't go through an evaluation. We could have, but I think it goes to speak to just how much information you can
Yeah.
get from where somebody hurts, what makes them better, what makes them worse, you know, when their symptoms started, how it started, all of that. And so if you're willing to take all those clues, and we do when we review people's cases, you're able to figure out the most likely source of their symptoms, and then you don't have to waste your time and energy figuring it out anymore, but you can just start to treat it. And by the way, how do we treat it? Just a little window into it. Well, you can't treat this thing. This thing exists on a picture here. But what you can treat is, you see that when you bend or when you move in this direction, it hurts? And then when you bend in this way, it doesn't hurt? Well, what's the opposite of hurt? It doesn't hurt. And so what is walking? Well, if sitting and lifting is bending forward like this, well, walking is kind of being like this. And so what if we take that clue and we have you do a bunch of backwards motions, because we know that already based off your story makes you feel better? Will it work or will it not work? And we would have to test. All right, now we're like 99-ish% certain that it's a disc problem. So I don't really, honestly, clinically need to go through this, but I figured I might show you. All right, so a very simple kind of exam that I could go through if she has a disc problem, and or I suspect that, to kind of tease things out, would be pretty darn simple. Here's what you could do. Stand on up. Go ahead and put your hands on your hips, feet shoulder width apart. Go ahead and bend backwards.
Ooh.
Okay, what do you got there?
Pain right here.
Good. You're great at playing the role.
Yeah.
All right. So this is what somebody with a disc problem would generally experience.
It actually does bother me.
Oh, it does?
Yeah, it
Nice.
does.
Okay. So, see, we're not role playing. This is real. All right. When somebody bends backwards and they have a disc problem, you will almost always see that when they get closer to the end of the range, or even sometimes within the motion itself, they'll have pain and stiffness. It could be one-sided, it could be both-sided, it could be central. There will be restriction to the motion. So they'll do it and they'll feel symptoms. So go ahead and do it one time.
Yep.
Okay, let it off. All right, and now here's the deal. Facet joint problems can cause the same type of stiffness. So there we're back to the conversation, although nothing else really fits age and all that. But you can say, well, how can you determine the difference? Well, it's central, so it's probably a disc problem. But you could do a repeated motion exam. So now I could say, can you do 10 of those, please? Can you do that for real?
Yeah.
If it's more comfy, by the way, you can turn your hands like this. Sometimes it's a little easier. So just give me 10 of them. Talk to me about what's happening. For real life, I guess. Let's do it.
Yeah. Well, it's actually getting a little bit better.
I lost count, but give me 2 more.
Okay.
All right, so as she's going, we're trying to see, can she go further? Can she not go further? Is the pain getting worse? Is the pain moving? These are all the things that I'm thinking about. Now, as you did it, what happened?
It got better.
Okay, it got better.
Yeah.
Did it feel like it was more stiff, less stiff, same stiff? I'm not standing on the side. Maybe you can comment from the video, but
I think it got less stiff. I think I was able to move better.
okay. This is actually typically what you would see with a disc problem, is that the more you would do a motion, the pain would generally get less, not always, but generally get less, or has the potential to get less, and you actually free up the motion. And this is more indicative of a disc problem or a soft tissue problem, because if you think about it, when you're bending backwards, if you have a joint or a bony block, you're not going to change that thing rapidly. And so you're just going to bang up, you're going to have end range pain, you're going to say, ow, off, ow, off, ow, off. Again, it's not going to be central, it's going to be to one side if it is a joint problem. But the fact she says, ow, it's central, central being most likely disc, age, all that other stuff we talked about. And the more I do it, the more I can go and the less it hurts.
Yeah.
Tells me that you might be changing soft tissue, you might be changing something soft tissue-wise, most likely being the disc. And so that would increase the probability of, hey, upon repeated motions into that yucky motion, 1 rep, there it is, and then it gets better and better and better and less stiff, that it is a disc problem. It's rapidly changeable. Now, if we weren't sure and we wanted to confirm it, then we should be able to rapidly reverse her progress as well, if we were being really evil or mean. And so what we could do is I could say, hey, go ahead. You could sit and do a forward bend, or maybe just lay on your back. So you can actually, no, put your head that way. Go ahead and hug your knees to your chest, nice and tight for me, for like the next minute. All right, so she's gonna do that. Hopefully you can see her over there. Again, you could sit in a chair and you could go forward. Now, you'd have to be careful. Disclaimer, if this was something that was too painful, because again, she's got trouble sitting. She's got trouble lifting. This is kind of like sitting and lifting, so just be mindful of that. But let's just say she held this for 30, 60 seconds. I like to do about a minute. Now what I want to see is what happens to her ability to bend backwards. So go ahead. Now stand on up and bend backwards just 1 time and get an idea of what happens. Makes it worse.
Yeah.
So now we see it hurt when she did it 1 time, and then she did it a bunch of times and it got better and her motion improved. And then I have her do the opposite, and then immediately upon standing, now she's jammed again.
Yeah.
This is probably a soft tissue change, probably a disc problem. So it's a kind of a sneaky way to assess for that, all right? There's probably other stuff we could do, but that's where I'd start. We'll keep it simple, and again, try that. If you're trying to tease out what could be going on, you're not so sure, go ahead, replay this, and try out this motion exam for yourself. So look, you can always check out other videos to kind of figure out the most likely kind of path you should take to figure out and fix these problems if you'd like. Otherwise, what I would recommend is that if you're interested in learning more and getting a complete flowchart and or mind map to figure out the most likely source of your symptoms, because maybe yours is a little bit different than this. We'll keep producing these videos, but just click the link somewhere in the description below to check out my Better Than an MRI DIY diagnostic guide to figure out the most likely source of your back, butt, or sciatica problem for free without an MRI. Thanks so much for watching. Hope this was helpful.